gentlemen, thank you. We are about to start.
Ladies and gentlemen, a warm welcome on behalf of the German Medical Association this morning. One day in April, millions of Europeans suddenly lost electricity. Within minutes, hospitals switched to emergency power. Medical practices had to suspend their work. Cooling systems for medicines failed, as did respirators for patients at home. Electronic patient records and prescriptions become unavailable. The failure of internet and telecommunication services led to a delay of several hours in informing the public. Healthcare personnel couldn't be reached, and surgeries had to be cancelled. None of this was caused by a military conflict, nor was it the result of a deliberate attack. Instead, it was triggered by a large-scale power outage in Portugal and Spain in 2025. Fortunately, the disruption was temporary. To our knowledge, both health systems managed to maintain patient care, avoiding casualties directly resulting from the power outage, but it tested the resilience of the health system. Preparedness and resilience, both included in the title of today's event, have become buzzwords. With Russia's full-scale invasion of Ukraine and its continuing threats against EU and NATO partners, Europe's security environment has changed. The prospect of health systems and suddenly having to cope with thousands of injured soldiers and civilians alike seems much more real than only 5 years ago, when healthcare systems were still struggling with another historical challenge, the COVID-19 pandemic. Next to military threats, hybrid attacks are becoming part of our reality. Cyber attacks have dramatically increased, and healthcare has become one of their main targets. Critical infrastructure is increasingly exposed, and disinformation has become a weapon. These threats may differ in nature, but they all raise the same question. Can our healthcare system continue to function when society is under extreme pressure? Healthcare depends on more than electricity. It depends on fresh water, on secure and seamless communications, on functioning digital systems, and let's not forget public trust. If these foundations are weakened, continuity of care is at risk. And whatever disrupts healthcare will, in the long run, disrupt society. Preparedness requires close cooperation between health authorities, civil protection, critical infrastructure operators, security authorities, and, where appropriate, military partners. Civil-military cooperation is crucial as it's strengthening the self-sufficiency of the population. The European Union has recognized this challenge. Its Preparedness Union Strategy of March 2025 provides an important framework. Its whole of government and whole of society approach reflects the complexity of the risks we are facing today. It includes a list of 63 measures to strengthen Europe's preparedness across sectors. These measures complement existing EU legislation of the resilience of critical entities on cybersecurity, critical medicines, and cross-border health threats. The need for European coordination in resilience and preparedness planning is no longer disputed. The discussion has shifted from do we need a preparedness union to how do we turn it into an operational reality? Because preparedness is not measured by the quality of our strategies. The only way to assess how well your health system works and interact with other vital societal functions is through regular drills. Hospitals, medical practices, pharmacies, laboratories, emergency services, and public health authorities all need to be included in realistic simulations. These drills should not stop at institutional or national boundaries. Every drill should end with an honest evaluation. Lessons identified should or must become lessons learned. And lessons learned should lead to practical improvements. This cycle of planning, exercising, evaluating, and improving is what creates resilience. In its first Prevention, Preparedness and Response Plan of November 2025, the Commission has announced simulation exercises for health crises. Physicians must be involved throughout the entire process, not only as stakeholders, but as partners. Physicians work across the entire health system. We understood how hospitals, outpatient care, emergency medicine, and public health function in practice, and how they depend on one on another. We also know where systems become vulnerable when they are under pressure. The medical profession stands ready to contribute. I am honored to welcome, together with our co-host Kassenärztliche Bundesvereinigung, distinguished representatives of the European Commission and the European External Action Service as the architects of European preparedness planning. And I'm equally pleased to welcome our guest from the Finnish government. It was no coincidence that the report that laid the groundwork for the EU preparedness strategy was written in Finland by the former Finnish President Niinistö. Finland's whole-of-society approach to preparedness has become a benchmark across Europe, and I believe we can learn a great deal from them. I'm looking forward to an insightful and inspiring discussion which I hope will bring us one step further to making resilient healthcare systems in Europe a reality. Thank you very much for your attention. And I'm pleased now to hand over to Eloise Stott, co-founder and director of the RAINI, Resilience Action Network International, who will moderate today's panel discussion. Thank you very much.
Thank you so much, Dr. Reinhardt. That was fantastic, and what a great scene setup for this discussion today. I loved that preparedness is not measured by the quality of our strategies. We really need to get to action and optimizing to understand what needs to be done, and that's what we'll be trying to get to today. So it gives me great pleasure to welcome up our distinguished panel. Without further ado, please give a very warm hand to our brilliant guests. We've got Sandra Gallina, Director General for Health and Food Safety at the European Commission. A warm hand, please. Dr. Tuula Helander, Director of Biotechnology and Medicines Unit at the Finnish Ministry of Social Affairs and Health. Commander Dr. Christian Hagenmiller, Medical Advisor of the European Union Military Staff at the EEAS. And Dr. Stefan Hofmeister, Deputy Chairman of the Board at KBV. Wonderful. We've got so many perspectives here. I'm excited for this conversation. And I'm going to start with you, Ms. Gallina. You've been at Sante since October 2020, but after decades of experience around the European Commission. So you have this kind of really 360 view of lots of different directorates, and for good and for bad. And so we'd love to hear from you about the European Preparedness Union Strategy. What's happened so far as you see it? How are you planning the follow-up? And what comes next?
First of all, thank you for inviting me here, because I think that, first of all, I'm sitting here with a lot of friends, including Eloise, that we had meetings in Sweden about the pandemic agreement, but also I would say the colleagues that are sitting next to me, in particular Tuula and Christian, are very committed. And I just want to say, Tuula, that I want to launch you a challenge, because we've just been to Romania with the Health Security Committee, where Dr. Raed Arafat showed us the preparedness of Romania, achieved with very small money, but European money, the SAFE fund. And I must say that we were all impressed, including the German representative that was there, because the Romanians know that they are on the front line, and that therefore, you know, anything may happen at any time. And what I appreciated, whether it is a whole of government approach or not, like in Finland, because in Finland we know that they have this, they really, you know, they drill down to the kindergarten, which is not what may happen in every member state. But let me say to you, we saw that there was in the bodies that were involved in this preparedness, so not only Dr. Raed's men and women, there was a dedication and a belief that they were doing good things for them and for everybody else. So this is a perception that I think can only come when community leaders, and I think that the reason why I'm here, I will be very transparent with you, is that a physician, just like a pharmacist, is a community leader. When we had COVID, we knew that it's the physician, the general practitioner, whichever way we want to call it, that the people were listening to, not the big voices on TV. So it's very important that this capillary structure, because every physician knows the people that he attends to, is also fed. And I must say that I was a bit worried now, because when you say physicians should be involved in the simulations, we have done simulations. I'm not too sure we have gone down to that level yet, meaning we get the contributions, but when we tested the last simulation we did, that for reasons of security I'm not going to reveal here, because my briefing has plenty of pages about that simulation. I said, horror! I'm not going to speak about the simulation. But let me say to you, how the physicians were involved, I will ask my team, because, you know, the hospitals are there with big surprises on how they react. But let me say to you how a physician is really involved. Now, to make amends of that, you need to know that we did a fantastic workshop where somebody who is present in this room was to give really a presentation. It was very good that Dr. Hofmeister was really presenting what it means to be delivering even more healthcare at the time when you are under pressure. That's the challenge. And resiliency is coming back to the normal, but the resilience is not the word that captures the moment of stress of the system when you need to do more at the time when you have less. And this was well understood in the workshop, that this is a conundrum that, A, we will not be able to solve so easily, because it would require money and investment that is not sustainable for nobody. Nobody can have that money. Or they can have money for specific segments. I suspect that, for instance, the US military might have that ability of a surge within the military, and henceforth on all the supporting part for the military. But for the whole of society to have a surge, it's just simply, you would need to have a double society that surges up to assist the society that exists. So it's not feasible. That workshop was very successful. We come from very far. So you mentioned the preparedness plan. So there is a plan. President Niinistö stimulated us to have a strategy, a very broad strategy. By the way, I want to say that that strategy was drafted with the Commission and the EAS together. So it's not just a strategy that belongs to the executive, only thematic, specific policy part. It's the broader geopolitical view that was inserted into it. We have then, within DG Sante, done this prevention, preparedness, and plan that has a long acronym. Union plan has a long acronym, but the issue is that this plan is not a sum of national plans, is how to coordinate at European level national plans that are sometimes very different. We are happy to have Tula. We could be happy to have Denmark also, because Denmark also has a whole of society approach. I was exposed to the fact that I was mentioning kindergarten, because the kids at the level of the kindergarten are in the drill. When they do the drill, for instance, they suspend energy generation to kindergarten, so they need to eat, I would say, food for that day that is not the normal fresh food that they eat. And believe me, the kids are very happy. This was the tragedy, that the kids said, we never ate so well. But apart from the anecdote, the fact that they were really testing it at the level of a kindergarten simply impressed me. So I mentioned Romania, I mentioned Finland, so I'm challenging you that you invite us to Finland to see how well you do it. But let me say, a plan, a strategy, but you need the people that move this. So you have seen here friends from EAS and from member states. The real center for all the preparedness at the moment after the serious cross-border health threats regulation revamp is the Health Security Committee, where you have two levels. You have the technical level. During Hanta and during Ebola, we have had almost daily meetings. My people were meeting almost daily with the member states. Some complained about too much coordination, but I would say those complaints were totally unwarranted, because for Ebola we had a very big external pressure, geopolitical pressure, to align to choices that do not belong to Europe. So it was very useful in the end to have a European coordination where all member states could say, we do it the European way. We are not closing borders with Africa. We are still staying open. I must say we had at the senior level fewer meetings, but very qualifying ones, where we were inviting WHO, but we also invited the doctor from La Charité that, with the discretion of the confidentiality, told us how they treated this American doctor. Let me say to you, today there is in Frankfurt another patient from the US. There is a reason why they don't travel back to the US. Those who know the issues, we were there in Romania and we could see how an Ebola patient can or cannot travel. The containers and so on and so forth. I will not go into these details, it's not for this morning. But I will zoom into the, I would say, the area that I think is more important for you. So, there's a plan. We are having simulations. So we didn't do a simulation with Hanta. It was really the implementation of the plan. Just yesterday, I got a debrief of the lessons that we learned from Hanta. It went very well, apart from the beginning. The beginning didn't go well. I will not go into the details, but we have the clear perception that at the very beginning, and here I come to the whole of society, there is an absence of responsibility from the ones who should be detecting what is happening in a boat, and also put a yellow flag in terms of the past on that boat, and not try to discharge people and put seeds of Hanta all over the place. We did a bit of a rather harsh analysis of Hanta. We are still in the middle of Ebola. I must say the Ebola thing is tragic. Yesterday we heard that Kisangani, which is a big city, is likely to be in the Ebola problem. It's not by dint of moving a doctor, an American doctor, back to Frankfurt that we will solve this. We need to solve this beforehand. And let me say to you, when I was dealing with vaccines, I remember that CureVac had a very nice library of vaccines, and one of them that could have been developed, mRNA, was Ebola. So we need to be preparing for these things, whether they happen in Africa or not. So you may say, when the member states choose the plan, do they consult us as physicians? I hope so. We have the distinct impression that there is more and more this clear perception that it is not just a hospital treatment that needs to be good, it needs to go beyond. Whether this happens, I see from the simulations that sometimes it's not happening. Meaning that we see that some people are almost taken aback by what is tested or simulated. Let me say that the last time we kept it simple. We didn't go for a military threat. We did a military threat in the past. It was quite difficult. So this time we went for a simple pandemic. We replicated a bit of a pandemic, and still I'm not happy about the results. It's much, much better than what we did in the past, but you know, we have to improve. And here comes where we have a big cooperation with Christian. So within the Health Security Committee, we have a subgroup, which is the civil-military cooperation subgroup. And, you know, I must say that in that group, there's a variety of experience. Funnily enough, those who are not in NATO are sending real military attachés, much more than others. So I'm just saying this because, you know, Europe is not all in NATO. We are working with NATO, thanks to Christian, quite well. One of our first actions was about blood, because blood needs to be transported safely. But when you have a war, you need to have blood close to the place. And by seeing where the blood is, you can detect where the next front will be. This is what they were doing with the Russians, at least, to see where they would attack, because the blood would move. We have had just recently, part of my team went to Israel, where we also saw what they do. Because one thing I want to mention to you is that don't be deluded that you're just moving patients from the front line to a hospital that is at the back. You need to move them much further. And the best is to have hospitals that you don't even see. So I need to look at my notes. I don't know if I will find it, but in this team exercise that my colleagues did in Israel, they went to see this underground hospital that Israel has. But let me say to you about mobility, we have here Tula, who may be telling you something, because also we had to solve it. This issue of moving supplies, moving stuff, is not necessarily, legally speaking, what the member states should do or would do. So we had one member state asking how was it possible that Finland was led to do this. And perhaps, you know, let me say to you, times have changed so much within the European Union, and this goes to, I would say, reply the very first question that Eloise is indirectly raising. I've spent 40 years in the Commission. Yes, and I would say that the big difference is that once upon a time one would go to the recipe book, meaning the treaty, and say the treaty says you need to do it like so. Today, the member states decide that they need to understand why a member state is doing something, and then see if this is compatible with the limitations that all need to abide by to have a bit of a coordinated approach. I'm just mentioning this because I'm very grateful to the Finns that they were able to show what they do, so that one single member state that had doubts got convinced. So there are many, the proof is in the pudding, so there are many angles, and my real concern for you today is that for the workforce, we are still doing trainings like HEROES or the European Joint Action, you know, on, I would say, the health workforce. But is this really giving us the tools? I don't think so. HEROES is a bit more about the resilience we need to develop. For instance, when we had COVID, we had this exhausted doctors and nurses. But are we really, for instance, one of the things we learned from Minister Liashko, in addition to the fact that it's not you move to the second row hospitals, but you move them completely away, which got Spain very much discussing in the HSC, because I am not keen on this. We said, well, you know, if we need to move them, we would need to move them more there than, you know, on the front line. So I don't go into those details, but it was quite difficult. And one thing on the workforce that is really missing in Europe, and we tried to do something with the small training action, is treating wounds from warfare. And the current warfare is particularly disastrous. So let me say to you, in a sense, we would need to have the expertise that I have seen in my many years of Africa, where, you know, you would have doctors that could sew and do fantastic things on incredible cuts of wounds that you would have. This is not at the moment so well distributed in Europe. So I just gave you an overview, a taste. I stop here, but I wanted to thank you for your commitment to go into an area which is extremely difficult for physicians. We are almost a generation, I would say, that has been used to think that peace is to be taken for granted, and that, you know, there's never this exposure to the extreme evil of a war. And I finish with the area where we are having most difficulty. It's the area where warfare is not conducted with, I would say, the normal means of the past, with a spear and an arrow. I would say, no. We have all these possibilities of spreading viruses, even modified viruses. This is why in my DG I have lots of work on AI and biosecurity. We will not go there in a public place like this, but modifying a virus for it to be impossible to understand is something very easy. How to sprinkle these things with drones. This was also a dramatic discussion I was having for the Olympic Games in France, where they were telling me, well, you know, it suffices for 1/3 of a gram of anthrax and so many people. And I was saying, what can I do? And so let me say to you, the war today is not just about a cannonade, but it's about these horrible things that happen. And the forma mentis of today's physicians is not necessarily geared up to that. So what we have found also in our simulations is that there is a bit of a resistance. So for the whole of society approach, we need to do much more to get the physicians to understand that they are the first post. I stop here. Thank you for the long piece that I developed, but I'm very and I'm in admiration not only of my colleagues but of you, that you want to understand this. So to be prepared, to be prepared means a lot. Means also to speak the same language, which was part of the workshop. You know that the hospital needs to behave in a certain way. That was also missing. NATO has a word book, and Professor Wurmbel was very good at explaining that. So I went completely out of my briefing, but I hope it was interesting.
Fantastic. Thank you so much.
Not at all. Not at all. No.
That was a brilliant opening, a brilliant kind of scene setter for our discussion. And I'm going to turn now to Dr. Helander. So you've got extensive experience, Dr. Helander, in the healthcare sector, including academic research, diagnostics and patient care, and legislation, national and EU. So drawing from your expertise, we'd love to hear from you about this brilliant Finnish whole-of-society approach, and what measures the Finnish government implements that make you more prepared. How can we learn from you?
Oh, thank you so much. I don't know what to start. Well, if you think about the Finland, I usually say that, well, the first thing is the people's trust. So if we lose that, we lose everything. But do we share the same picture? So I think it starts from that. But if you think about Finland as such, well, only 5.6 million people are living, so that's not much. But if you think about the space area, I usually say that we are not a small country. As a matter of fact, then that is part of the challenge. If you think about, usually I say that, you think about the Helsinki, which is a very southern part of Finland, and then you go to the Lapland, it takes non-stop about 16 hours to the Lapland, to the northern part where the Santa Claus lives. So that it's really well, and usually I say that, well, we have 1,350 reasons to be prepared, and that's the kilometer borderline with Russia. So that I think that is one of the things that we have every day. Let's say the geographical location have always been a part of our politics. So we have understood that we have to be prepared. So that I think that is the one thing. So that and people are very committed. So very committed. If you think about still even the younger, maybe not the kindergarten, probably those as well. But they are, the young people are very committed to that we have to secure the whole nation. And for example, I have 2 boys, and they went to the army. They served the whole year, both of them, and they were very committed and very happy to do that. So I think it's a history, and of course we have the grandparents. They have the history. And we tell them, of course, we share those things, that they understand what we are achieving and what is the meaning of that. So, but if you think about the whole thing, so I think that one of the things I remember when we're thinking about I was then working at the Helsinki University Hospital, and it's very big hospital. There are 26,000 people are working in that hospital, so big hospital. But then we thought about because we have a lot of clinical trials, but what about the other, if you think about the rural areas, do they have the same opportunities to participate in clinical trials? No. And especially those people who are living in rural areas, not in the, let's say, in the university hospital nearby. So we thought that no, we have to have national coordination. And that was the first thing we then established: National Cancer Center, National Neuro Center. Of course, we have this university hospital, but at that time we already understand that this is not just, organized by the hospitals. We have to have universities because the research, if you think about the researchers, and then what about the economy and the finance, and then we then build up a growth sector, a health sector growth strategy, and all government. So it was in a way that all the governmental ministries must be involved, because it's not only a case if you think about our social and health ministry. And in addition to that, I didn't know when I went to the ministry that we are in a way quite exceptional that we have social affairs and health at the same ministry. And if you think about the sensitivity data, a little bit probably here and there, but then if you think about the social data, it's even more sensitive if you think about the health data. So, and that's why we understood that we have to have the legislation, and then before the ASDS, which is very important, we have that legislation for secondary use of social and health data, so that we can use the data so that everybody understands that the results comes from the research, but how to integrate the data to the healthcare, and the loop must in a way functioning. And I think it's in a way stepwise approach if you think about the health, the whole, let's say, whole government and whole society. We have this security strategy for society. I think that's version 6 by now, and it has been now updated more often, so that I think it's not only that there are so few people living in Finland. I usually say that we have to have many hats that we get the things done, because there are so few people. But at the same time, I think in a way it's good that we have understand that, for example, Helsinki, it's not enough, and the Finland, it's not enough. We need the whole EU. We have to have the benchmark, because there are, as Sandra said, there are even not in Europe, but there are in Africa, there are in South America, there are beautiful examples that we can really, and they are very quickly, they have just decided that, we have to do this because we have to have the resilience. And I think that one of the things that we've been discussing, that in Europe, do we lack courage, so that we should just go forward and that not too much think about that is everything in orders, because in time it takes a lot of time, and that's why I think that the omnibus is in a way good, that we can really do something, that because the legislation is so complicated. I just said to my lawyers that, come on, we have 500 pages our proposal for the parliament. Who in earth is going to read that? So that we have to do something, so that, because these things are not that complicated, so that I think that is the one thing that we have to think about. What are the goals? And I think that as you were mentioning about the simulation, we very early on, we understood that if we don't we don't do rehearsals, we don't really know how prepared we are. We have to do that. And I think that has really opened our eyes. Unfortunately, the COVID was one of the rehearsals, so that, but in those times, we really understand that we are not prepared at all. So that there was, for example, I think we really overacted, because we closed closed borders in Helsinki city area in that time, because we didn't know what in earth is going to happen. And later on we noticed that we shouldn't have done that. But in those times we really didn't have any cookbooks that we could look at that how these things are coordinated. So I think now we are really a little bit more, let's say, more aware of those things. But still, I think there are many things we should do. And one thing is that, yes, the coordination, what that is mean? It means leading, so that that we should lead, and let's say to. Maybe one of the things when you're thinking about the leading, it's not ordering, because as you all we know that it's very difficult to say that, yeah, you should just do that if they are not already committed. So we have to share the same picture and the goal, so they know what we are achieving at. And I think that is one of the things. In a way, I was proud when I look at the vaccination rates in Finland in those times when COVID started. It was over 90%, so that the public trust for the authorities and the police and so it's very high in Finland, and that is the one thing we try to treasure and cherish that. And usually I say that if you think about the biggest challenges, yeah, we know we can list those, but what about the mis and disinformation? Because I see that is a really tsunami which comes. So who are the ones we really trust? So that I think that is a big issue. What in earth we're going to do with that? If you think about all the channels we are, let's say, we see, and what about the children? So I think that that is the one thing we try to figure out what to do in that. So that's why we need the expertise, we need the trust, those people that we know that it's evidence-based, and that's why I think we are a little bit worried if you think about the States, so that what is happening in US, so that I think the Europe must stay strong and say that we are evidence-based continent, so that I think that is one thing, because only if we have that information which can really rely on, we can do something and we can achieve something, and it's part of this whole society security plan. So I think that, and it's as that is true that the strategy, it doesn't really solve everything. No, it doesn't. But I think it's a start. It's in a way start that we share the same picture, and then we do let's say the implementation phase. And it's a stepwise approach, and that has been in Finland as well. We noticed that okay, we are not there yet, but we are ready to go forward. And the one thing which I really let's say cherish and are so happy that the European, I think we are doing better together now. Yes, so that much better. Yeah, that's true. So that
it was visible. I would say to you, in Hanta it was visible that we didn't make any of the mistakes of the past. Yeah. We went very well. In Ebola, again, I can see that we can improve on things. Yes. But it's
much better. If you think about the COVID times, it was totally different. We were. So that I think that those rehearsals showed us that we are really powerful together. So maybe with these words I don't continue, so that maybe later on, so that the other experts have the space.
Thank you so much.
Yeah, thank you.
Thank you, Dr. Helander. Always fantastic to hear from the Finnish experience, so thank you for that. Now turning to Commander Dr. Christian Hagenmiller. So in your role, Dr. Hagenmiller, you support strategic planning, CivMil cooperation, CBRN threats. So you've kind of got a really good insight into all of this current work. What have you observed as being those concrete benefits of preparedness planning at the EU level, and which pieces should be kind of more top-down or coordinated, and which more bottom-up?
Thank you, Louise. Now you are asking me, military, about the top-down and bottom-up approach. So
I can guess which.
But no, you will be surprised how much the military is also embracing the bottom-up approach. And I think this question is quite important because we can discuss this in a bubble, everything is in a sterile environment, and that's fine. But if we look outside how the population feels about the EU, there is always the sentiment that there is that kind of top-down approach that EU is directing, the EU is, let's say, mandating, and so on. So having a certain transparency here is, I guess, it's spot on, and this is what we also owe the population of the EU. But by starting by that is, of course, we have to say that national healthcare systems are national healthcare systems, so they have their own responsibility, and we will hear just in a couple of minutes about the German system, where it's really parceled much more down into the local areas, where really the local ownership. So having really a top-down approach, this will not always work, because what we want from the local system is that kind of adaptability that we can't generate at a higher level. However, and that's the reason why we are also sitting here, is we are facing, we had COVID recently, and we are facing a geopolitical situation where we are all clear with all the threats that comes, with all the disruption that, let's say, an armed conflict can bring with it, be it cyber, be it infrastructure, supply chain, and everything. Everything will be cross-border. And here, again, no nation will be able to solve it alone, and this is where the EU kicks in. We have what the EU needs to do at this point is, of course, providing interoperability demands and challenges. And this is what we also are looking now in the minimum preparedness requirements that are now recently developed by here in the Commission, and we are also a bit involved in that. This is also aligned with the NATO 7 baseline requirements. I don't know if you're familiar with that, but this is also really a kind of checklist of for nations. Hey, have you thought about those issues? And it's a kind of helping the member states. But the idea behind is, of course, to having something coordinated, or something speaking the same language, and having that kind of interoperability aspect in there. Additionally, the UCPM mechanism that we have, it's really pooling resources that are available for countries. That is certainly, it has to be on a top level. Also the option that EU and NATO can talk and coordinate. This can only be here at a EU environment where there is. This needs to be at the top and macro level. I just want also to emphasize that the EU is really bringing the core of it, its solidarity. It's strengthening that kind of collective capabilities. And this will lead to more deterrence. This is actually what we want, specifically from the security angle. However, yeah, that's the thing. We have, of course, the bottom-up approach, and this is that was also the question. Lessons from Ukraine. We see that a lot of things is coming bottom up. The whole drone revolution that we see in the battlefield, but also we see that on the medical side. We see that they are trying to test medicine in this situation under those conditions. Does it work? Does it not work? We are changing our protocols that we are dictating top down. We're changing that because we really learned the lessons from Ukraine and said that is purely bottom up. So you see, that's the thing, and we are very happy to have our technical working group, that the civil-military technical working group, that of course it's more on the macro level, but we want to embrace also those angles and be a kind of linchpin in this area. So, but I also want to say, okay, we need to, the way to go is having that kind of fluid model, not having kind of barriers, this is top, this is bottom, and this is, we need to have that kind of fluidity and embracing that. And if we talk about the healthcare system, of course, there is the kind of sentiment, okay, we think about preparedness, hospitals and things like that, and so that it's much more, and it's much more, it's everything, the whole scope that we just heard about this, and this is really living both areas, living really and learning from each other, and we need to have those mechanisms in place, and the EU has really learned, and not only learned, implemented so much. There was a very steep learning curve in the last year or last 2 years since the Minister report came out and so on. It's really mind-blowing. If you criticize the EU, just look what happened the last year. So yes, even this level here can learn a lot, adapt also quickly. And we need to support, and we're very much looking into the Finnish, we are very much inspired by Finland and also the Baltic states, because this is really getting the lessons and also influencing all our work. And I will stop here. And I think that will be, it's a good transition to my
Thank you so much, Dr. Hagamiller.
Bravo, Christian.
Thank you. So moving now to Dr. Stefan Hofmeister, so Deputy Chair of the Board of KBV since 2021, and also now President of the Federal Association of Liberal Professions. So from these different perspectives that you hold, I wanted to ask you about the fact that medical facilities are increasingly targets in military conflicts. So what's the adaptation to this, the more decentralized structures, like the practices of the office-based physicians and psychotherapists in Germany? Tell us a little bit about that and how that adaptation needs to occur.
I will gladly do that. Thank you for the question. If you allow, being the last speaker gives me the opportunity to focus on one common theme that I want to use to personalize this discussion. Who in this room has stock of the recommended things that you should have in case of crisis or war? Raise your hand, please. Okay, that's about what you get when you ask this question. Now, my second question is, what will happen at the hour zero if and when something happens? Will we all need help then? Yes.
Yes.
Who is going to give us help if we all need help? So resilience is a question of my own attitude. It begins within us. And of course, we're here all responsible for political parties, for governments, for EU institutions, and we have a lot of work to do and we have a lot of responsibilities, but resilience begins within us. And I think that's something we have lost in Europe, and the Scandinavians, especially the Finns, but also the Baltic people are much further ahead, and why you said that 1,350 reasons, they're closer to the border where there's war. So that was very important for me to address this, because it leads to the second point and to the answer to the question, decentralized structures. The Ukraine shows us that, as in many other wars before, any medical support points are prime attack points. So the Red Cross is not protection. You remember Afghanistan, we covered the Red Cross because they were used for the bazookas to aim. And if it's enough in Ukraine, if the Russians see like Band-Aids lying around or stuff that suggests there could be a medical point, that's already enough reason to attack some place. So the answer is very easy. Yes, it needs to be decentralized, and we will not have time to dig our medical facilities underground like they did in Israel. I mean, that's just going to take too long. It would cost billions that we don't have, so that's not realistic. When we started, when NATO started addressing this, you know, they have what they call OPLAN, which is a secret plan, but it covers what will happen in case of a crisis along the border, war, or Article 5. And then we're talking about the severely injured soldiers coming in. 1,000 a day is kind of a rough number, and everyone will go through Germany, as well as all the soldiers going east will go through Germany because we're a transit country. So there's a big issue. We will have to cope with many more people.
Yes. Yes.
We focused on those clinically severely injured people at the beginning, which is normal, understandable. So all the focus was on hospitals, which, even though Germany has many hospitals, is a huge challenge for us, especially when you think about these hospitals will be under attack. Asymmetrically, probably, not by missiles, but cut of power, cut of water, pollution, sewage plants, shut-offs, etc. What we kept forgetting, what we did not talk about at the beginning, 97% of the medical treatments in our society are done in ambulatory care.
Yeah.
And that's going to stay that way because we have soldiers coming east, we have wounded coming back west, but we will have millions of refugees running from the borders. Refugees that are not severely injured, but that carry all the chronic diseases that we have. They may carry this and that. They may not have their vaccinations, whatever. So we will have immense challenges for regular medical ambulatory care. To give you a number, we have 1 billion patient-doctor contacts in Germany in a year in peacetime. 1 billion.
1 billion.
So you can imagine that I'm not too afraid about another million coming in. That's okay, we can cope, but it needs a lot of preparation. It needs information. Who are they? Where are they? If they had a medical record, wonderful. So that's something we need to address.
If they are
We have 110,000 medical offices with physicians, specialists, GPs, pediatricians, and psychotherapists spread throughout Germany. They're independently working, so they have an intrinsic motivation because they live where they work, and it's their work, it's their business, so they have no reason to run away, and if and when they're there, they want to work. I mean, they're medical professions, they want to help, they want to do their work. So what do we have to do? We have to make sure they can do their work. We have to make sure they have electricity, they have water, they have medical supplies, because they are not logistics. That's a medical office cannot do that, and they don't have time to do that. They cannot provide IT. They need to be provided with IT. So what we have come to discuss in Germany, as well as with the EU partners, as well as with our military, where we have a very close connection with in Germany, is how can we make sure that those offices, those medical offices, can stay and perform medicine as long as somehow possible. Decentralized, like a beehive or an anthill. It's not top-down. You cannot call from Berlin and command what they have to do. They know what they have to do. They know medical treatments. They know what to do. But we have to set the environment for them. And we're working on this. And the biggest issue is the intrinsic motivation of everyone working there, because if everybody runs away, or, you know, we have the issue about draft in Germany, and I hear interviews with young people, 18-year-old, being asked, are you willing to join? And the answer is, no, the state hasn't done anything for me yet. And that makes me sad. And with that attitude, the whole system will not work. So what we need is intrinsic motivation. We need everyone doing his or her best, and then those medical facilities being provided and taken care of, being supported with logistics, with medication, with electricity. That's stuff for government. Then we can be strong, and we can treat people, and we can treat more. And Sandra Galino was saying that we will have more work to do, more. And we will have to let go of some of the routine work. That needs to be told to the population. My last sentence, if you lose the trust on the home front, you lose the war.
Exactly, you lose everything.
At the beginning, when the first thoughts were, we will draft all those physicians, those 198,000, and put them in the military, we were saying, no, that's not a good idea. If you take a GP from his home office, you will leave 100 patients a day without a physician. That's going to cause trouble at home, so that's not the issue. And we've solved that. We're much further than that. We're saying, let them stay where they are, improve their stability, working stability, make sure they can work under severe conditions, communication, information, digitalization. These are the issues, and that's what we should be working on. Thank you.
Thank you so much.
Bravo.
So, Sandra Galina, I know you have to go shortly, so I wondered before you go, if you could just maybe give a couple of reflections from what you've heard from the other panelists.
Thank you for giving me this opportunity to interact, and you will allow me to interact really in a very direct way because we know each other in this panel. So, first of all, I want to clarify for you a few things that may be troubling your mind because the physicians in Germany in particular have had a very big role on the European health data space. I want to be very clear. The fact that you may not have had the boon of the digitalization of Finland is even a bonanza now, because you can jump already. It's a bit like the Russian Revolution. You jump over perhaps that was not good that they jumped over the French Revolution ideas so that they got to a different, but let me say, you are jumping to the end result. The database stays home, because one question I got from AfD when I went to the Bundestag is, well, I say, the data is yours, you manage the data, nobody is accessing those data. I will not go into that because you can imagine that GDPR is difficult, but health data is even more sensitive. And imagine that, for instance, in Estonia, you have the possibility to even hide certain parts of your record to your doctor. So let me say to you, these will stay, these things. We are not changing because this is the problem that Europe dictating. No, we're staying. So first thing, and why am I quoting EHDS? Because EHDS will be a massive vehicle for the resilience in terms of transmitting data. Now, another piece, just reacting for you to clarify the scene. How do we work all the pieces of this barack together? It's very easy. I have more or less the responsibility to be extracting from the public health authorities the algorithm. And the algorithm means that there is a lot of legislation. For instance, you were saying Germany is a transit country. For blood to be transiting, for troops to be transiting, we need to have legislation. That is me. We have already had enormous experience, unfortunately, but also fortunately, with the Ukrainian, the war of aggression of Russia on the Ukraine, because we had a huge influx into Poland. And I can tell you, my first problem was that I had this fantastic doctor in this place where I can never pronounce the name, which has become the hub, whatever the name. It's always my good friend Maciej Popovsky, yes, that pronounces it. And the problem was that she wanted to load buses. And I said, we cannot do that. I need the name and the identification of every person. And thank God we did that, and we were a bit at the beginning. We spent 1 week on that issue. I can tell you it was not amusing, because the people upstairs were saying, but what are you doing? Why? No, I say, I cannot load the bus. I need to have in the EWRS, which is an acronym for a very securitized database, I need to have the name and the identification of every person. Because when they arrive in Germany to be treated, or in Spain, hopefully, then the Ukrainians wanted to know where they had gone. And here Christian knows why some were more researched than others, because, there were a lot of military or young men that were coming out. So let me say to you, we were not asking them whether they were military. This was not the field that we, despite the request of the Ukrainian, included. We don't know the status of the people that we're treating, but we know their date of birth, their everything is there. And this is a detail. I'm just giving you this because the physician that will get to be involved in this needs to know that this is not improvised. So we have many pieces. On the issue of the hospitals underground and all, I want to give you a bigger reply. So first of all, the small reply is that there are many parkings that are unused, and we saw in Romania that they are thinking of that. You know, now we went for bicycles most of the time. Even in the European Commission buildings, there is floors and floors that can be used. But even without that, I will tell you, the key to success in preparedness is to have dual use. But dual use means that a doctor that is a civilian is somehow treating also war wounds. Secondly, that every civilian is a dual-use civilian, meaning it becomes a dispenser of services at the time when there is a need. So the question is not who helps me, is how I help others. That's where we need to get. But to get there, unfortunately, our societies are very resistant, And I speak as an Italian, which even 2 days ago, there was somebody on the television saying, no, but Russia will not invade us. Of course they will not, as they said in the past, have their horses drinking water in St. Peter's Square. But that's not the point. The point is that by having a war with us there on the border, they're putting an enormous pressure on our economy. Our economy is being strained. We are paying enormous, I mean, I like to help Ukraine, but you know, these are billions that we're spending and all these things that we're doing. So the war is already taking a toll on us, on Europe, on the European economy. So let me say, the forma mentis is not there. I'm sorry, our societies are still very resistant to this. So the real question is, how do I help? In Finland, they have that. In Finland, believe it or not, they are dispensers of, they know what to do at the time of an emergency. And there is a lot that we need to do, but we are much better prepared than we were. I want to confirm this to you. And I want also to say to you that we need to be somehow very much aware that there are disinformation campaigns. I'm very grateful to the Director General, she's a Romanian. She's doing every week, Dana Spinant, who was working for Politico many years ago. She's doing every week a very short summary, because we don't have time as Director Generals to read, as you say, all these pages. But it's a one simple page where she lists the campaigns, generally Russia-driven. And the campaigns, you know, they are like projecting that Europe is weak, projecting that Europe... No. We are strong. We have a certain resistance to certain topics. War is not something that anybody likes. But let me say to you, I count on the physicians also to come out from this idea that there is only peace and love around us. There needs to be a bit more awareness that sometimes when you see, and this the veterinarians have already absorbed, when you see a certain disease all of a sudden happening, like in the middle of Europe, in Czech, we had African swine fever of Pakistani strain. Let us be a bit smart and think, why is this happening here? So always beware that not all happens by chance. The cyber attacks are very bad. We don't give oxygen to them. We should not give oxygen by saying we have this attack or that, the other. So I want to recomfort you on the fact that we are not improvising, we are beyond improvisation, but we are now discovering the gaps, and the gaps require a lot of time, but there is a lot of dual use that can go on. We should not be thinking, this was one of the lessons of the Romanian trip. For instance, I will not say who, but it was a very prominent member state that was saying, but we need a specific plane to transport for so many hours an Ebola patient. And this was not correct. What is correct is that you need a special container whose doors are even produced by NASA. I mean, it's really aircraft that goes into space, those doors. So it's not technology that you can have on the hoof. So again, we go back to the European strategic autonomy. We need to be able to be autonomous. Vaccines are European. mRNA is European. mRNA was produced by a European company, BioNTech. Yeah. Then it became BioNTech, Pfizer. Yeah. But let me say to you, it's BioNTech that knew how to do it. Not CureVac was very much advanced. This is European. My heart bleeds. I went to San Diego. We have all these brains, young brains that go for biotech in the US. Because they don't have the money. We need to put our money not in funds in the US. We need to put it for us. Sorry to sound very belligerent, but the preparedness starts there, that we have the knowledge, because a lot of biowarfare is coming. We have the brains, and they are very imaginative, these young people. But of course, they go and work for China. They go and work where they are paid. So you are physicians. You need to be the first port of call, but you need to have a society around you that also understands what you want to do. Because, you know, we lived it in COVID, how much disinformation was spread around mRNA vaccines. You know, somebody was jocularly alluding to the famous issue of the chip, that we were injected a chip, you know. When I hear that, I just get horrified. But, you know, to cut a long story short, this panel was precious because we are really working. We are trying to give you a few ideas. Come and give us what you need. You will have a digital highway that you didn't have to be better connected. Europe is no longer so fragmented as it used to be, so we are learning from each other. Unfortunately, Ukraine was a big laboratory for us, big laboratory. We saw things that we need to do. And, you know, practice makes perfect, and here is where the simulation, I must say to you, the ECDC, we are doing the vetting of the plans. You know that every member state should have a plan. This is also something where some member states have a good plan, some other member states have a plan where they need some support. It's also a matter of money. But, you know, we're trying to go together, because alone you will not be, I mean, if all the others are in a bad situation and they all come on board Germany will sink. So it's not sustainable. We need all to be prepared at home, literally at home, literally at home, which is not yet there. But we will arrive there. I'm an optimist, and, you know, I wouldn't be doing this work otherwise. We will get there, we will get there. But it's the mind of people. The mind of people is still in peace and love, and all like us, and all not so sure. So thank you for this fantastic opportunity. I would not have missed this morning meeting, even though I am in terrible moments for, I mean, this is July, is the end of before summer, and I need to go back because I have a few parts of the kitchen exploding. But, you know, I'm grateful because you are at the forefront. Remember that we know that during COVID, you were at the forefront, and sometimes you were left alone. And this you don't forgive us for, but things have changed. Things have changed. All governments recognize that you are the first port of call for care. And care is many things, psychological also, you know. So, million thanks for this opportunity, and thank you to all of you. Thank you.
Thank you so much, Sandra.
Thank you. Thank you. Apologies, but
no,
I disappeared.
Yeah, thank you so much.
So let me kiss
I will.
my accomplice.
I will move over.
We come to Finland.
Welcome.
And
Thank you, Sandra,
for the workshop.
Thank you.
This man was good at the workshop. Thank you. Grazie.
Thank you so much, Sandra Gallina. Should we give her another round of applause on the way out?
May I a little bit continue about the preparedness?
Please.
Because I was thinking about where are our data platforms? we were discussing about that, about the securing data and sensitive data, and we just had a project with 1 million genomes. We just made a synthetic genomes because we thought that this was one rehearsal, how to really share the data then across countries. As Sandra said, it's access to data, but anyhow, we thought that how to really build up this. I have to say that, okay, we have that supercomputer in Lapland area, and I think it a little bit shows that, first of all, the amount of the data. It was challenged that, okay, do we have this, we are talking about AI factories and the platforms. I remember when our IT guys called me and, okay, now we have that the data, 1 million genome, whole sequence genomes. When it was opened up, it was 200 petabytes. And because it was a raw data, we have to double it. It was 400 petabytes. Well, I was like, what in earth, how much is it? It's all the literature you have ever published and then multiple thousands of times. It's enormous. If you think about the CERN in Switzerland, I think a couple of years ago, the whole amount of data, the storage were for 700 petabytes. So you can imagine it's a huge amount of data. But anyhow, then we were talking about, well, what about our lawyer said, well, it's a little bit, the supercomputer platform is not that safe. And I was thinking about, what about our hospitals? We have Microsoft Azure. So who is, you know, as we all know, is that, what about that we are storing all the patient data there? So I think we have to open our eyes, what kind of platforms we use. We need a European ones, so that and if you think about the AI, who is educating the AI? Because that is the one thing that's why we made the synthetic genomes, that we can really educate the AI. But as you know, who is in the background of AI, if you think about the Copilot, it's the same Microsoft. So I think that who is, in a way, guiding us? I think this is a key questions that we have to be prepared and think about. I think maybe not really painting all the risk, but I think the importance is that we identify those things. Then we are prepared. We identify first that, okay, we understand that this is, of course, it's always the balance. And Sandra was referring to ASDS, European Health Data Space. I can say that Denmark and us, Finland, we were a little bit against one thing, the opt-out. Because it was that the people need, we need that there is a possibility to us to say that, okay, maybe I shouldn't give the let's say the allowed to use my data. And we need the informative consent. I'm asking, are we really know, do we know what we are opt-outing for? Do we know? I bet that after 10 years, there will be patients to come to me and say, you didn't tell me that now you can't, there is no possibility you to help me because there is no data from me. Because we have already preventive these projects where we can identify, people have given the consent for biobank samples to get that, and then we have already asked those people, because they are citizens, are you ready for information if there is something recognized, something very risky. And we have that project that, okay, there are hereditary breast cancers. We see them already when the lady is born, that she's in very high risk to get breast cancer, for example, in 40s. It's a 70% risk. And we had that, so that these ladies said that, I didn't know that. And I remember when the young one, the 19-year-old, said that, I didn't know that I had this risk, and she did the Angelina Jolie, so she gave the breast, and it was under 1% the risk after that. But I remember when my lawyer said to me that is illegal, that you can't, in a way, recontact people. And I ask everyone, if I'm, let's say, 40-year-old lady, and I have 3 kids, the youngest one is 2-year-old, and I have a very aggressive breast cancer, but I hear that you knew that when I was 18, and you didn't tell me. So is this really the right situation? Isn't it that citizens, they are allowed to know? And and this is a real example. When I was working at the Home Comprehensive Cancer Center, there was an 89-year-old lady, and she had 3 kids, and she died when the youngest one was 2-year-old. And in that time, I said, we have to do something, because we know that she have that high risk. So I think this is the one thing that we need the information, but how to secure, how to manage it, exactly. So I think that is the one thing. Yeah.
So that's a great point, and that whole data track, cybersecurity, very important. I am going to come to the audience in a second for questions, so please let your questions cogitate. Just very, very quickly, if I can ask for like a 1-minute answer from you both. I just wanted to ask one question while the audience are thinking about theirs. If we were confronted with a large-scale military crisis tomorrow, what would be the greatest vulnerabilities of our healthcare system? If I can go to...
In 1 minute? So I can
you can have a minute and a half.
It's secret. So then I...
Oh.
No, but okay, now the thing is, of course, that's a sensitive question where you have, you need to be clear about your vulnerabilities, but it's of course so that we can do our homework. But of course, you don't want to show them too much to others that are abusing that. Luckily, you've asked for tomorrow, not an attack or tomorrow and not tonight. But the thing is, we have to think about what kind of attacks that would be. There are different scenarios, and each scenario will have another set of impact and vulnerabilities. If it's hybrid, where, let's say, assuming the whole Europe will be affected everywhere equally, cyber or whatever, or if it's just one nation that it's isolated, and the whole solidarity system will be, let's say, challenged, because I'll say, okay, should we really help and then getting involved? Or is it a multiple national front? So things will depend on that. But I just want, and we spoke already a lot of things, but I just want to maybe to use that minute in highlighting one aspect that we haven't really touched so far. And it's really the incredible innovation cycle that we see in exploiting exactly that knowledge. So as someone said recently, without AI, Ukraine would have lost the war already. So it is really the that technology, artificial intelligence, that they are using to protect and defend themselves, but also how that can also be misused to understand exactly those vulnerabilities. I'm just also saying because we are at the moment trying to have a kind of dashboard of military mobility. So in saying, okay, what is working, which is here and there. So just imagine that that this tool is in the wrong hands, and but we need that. We need that. Otherwise, we will not be able to let's say, identify our choke points and also to play around and to red teaming it so that we can really do something. So there's. I would really keep that question for a red teaming exercise using latest technology that is available. And I'm saying latest technology, I mean latest technology. Really talk to the high-tech people, even if it's not European, but this is where we can advance.
Thank you so much. Any thoughts before I open the floor?
I would like to divide this in 3 portions. The one is human resources. That's a big challenge. One is who is going to run away, who is not going to be there. Ukraine has been hit heavily because they let people leave the country, especially females, and then they realized females are the most common providers in medical care. So they were drained, and we have double or triple assignation, also a problem. So we don't have an accurate head count. So at the very beginning, we don't know who's like me, a reservist in the military and a physician and something else. And who's going to get me when it's there? So that's the one sector. Second sector is delivery on demand. Our entire logistics system in the European world consists of trucks. We don't have any stocks anymore. So as soon as we run out of medication, the question is, with disruption of infrastructure, asymmetric warfare, will we still be stocked and will we have supply in our medical facilities? As I said, we are not logisticians, so we can't do it. We depend on that. And the third thing is very obvious. As I had my little survey before, same applies to a medical office. If you have no electricity, no water, you can flush the toilet once and that was it. And how are you going to provide medical care? You need a lot of equipment that needs electricity. You need water, of course. If that's only in an area, we can cope. Like in Berlin, we had 2 power outages, one before Christmas and one in the spring, and the second one was even bigger than the first one, and 135 medical offices and about 10 pharmacies were off the grid for 7 days. Now in Berlin, that's okay. You can send people to other places, but if this happens in a larger scale, then we are in trouble, and we need to work on workarounds for that. We need to have default systems, fallback systems, which we did not need in times of peace and happiness for everyone, which we're not in anymore. So,
Thank you so much. So over to the floor. Does anybody have a question? I'm going to look for my microphone holding friends. Please make your hand very visible.
Thank you. My name is Manuel Ballotta, and I'm the Project and Policy Advisor at the European Federation of Nurses Association, based here in Brussels. Mine is more of a comment and an invitation for reflection to the speakers. And in fact, when we think of preparedness and resilience, we really need to not work in silos, and we really need to look at our healthcare workforce as a whole. And we need to make sure that we work with the physicians, with the nurses, with all the allied healthcare professionals. And this needs to be both at the local level when you plan and deliver care, but also in the way care is planned when it comes to preparing for crisis at the higher level, when we talk of top-down and bottom-up. So I hope that this can be done efficiently, because sometimes it's still a bit missing. And I'm curious to hear your thoughts on this. Thank you.
Thank you. I'll take several rounds because we're... I'll go over here, and then there's a couple over there as well.
Right. Thank you very much. First of all, for the very interesting debate. My name is Philipp Lazan. I'm working for Fresenius. We're a global healthcare company. We're producing generics for patients in critical conditions. We're one of the last remaining antibiotic producers in the EU. We produce blood bags, and we operate hospitals where we also take part in resilience exercises in Germany. One part of the discussions which I think was missing is the question, how do we finance all those resilience and healthcare measurements we're going to take? Is that something which should be financed by the national healthcare budgets? Is that something industry has to take over? Or is that something we maybe should see from a rather broader security dimension and linking it also to defense funding?
Excellent question. Take a couple more comments over here, and then I'll turn to the panel.
Thank you very much. My name's Kitty Mohan. I'm here from the British Medical Association, and it's really interesting to hear the discussions today, because obviously we are having very similar discussions in the UK across all levels and within the BMA as well. My question is really about skills. We've heard about knowledge quite a lot, and about skills and having the right skills within our medical and health workforce. I'm a specialist. I've been a specialist for almost 10 years. It is well over 20 years since I worked in any sort of trauma. And our military physicians, I'm sure the UK is not alone, where we have a finite number of military physicians, both active and those reservists as well, who have seen what could be on our doorstep and coming in if we are in whole-scale war more kind of across the countries. So how do we train or how do we ensure that when we are able to have our facilities running for our healthcare to continue, that the physicians and other healthcare professionals know what to do, that they are skilled up to do things that they may not have seen done or the conditions they may not have seen before, and how can we do that for our medical students as well, because they are obviously going to be coming through. Thank you.
One final remark, and then I'm going to turn to the panel.
Hello, my name is Adam Ogaleski. I'm from European Federation of Public Service Unions, and we represent healthcare workforce from doctors, nurses to medical administrators. And I would like to ask the questions about the financing was already asked by our colleagues from Fresenius. We also have the European Works Council. But my question here is more about the vulnerable population. I think we learned from the COVID pandemic that the older people in the care homes were the most affected because there was no cooperation between health sector and the care homes. You also mentioned these drills in the kindergarten. But given that the society is getting older, the European society is getting older, is there anything planning in terms of how we support the people in the care homes or those who are very, very old and vulnerable? Because I think this is, they will be there, so how we could be able to ensure that we don't make a mistake like we did during the COVID pandemic. So that's my question. Thank you.
Great, thank you so much. Who would like to chip in first? We're sort of running a little short on time.
Okay, so let me just, I think I can say something very short to all. Of course, we're talking about all medical professions here. That may not have been stressed enough, but we've addressed veterinarians, very important. Nurses, PAs, I mentioned, it's a matter for all of us. We need to work together closely and on the same level. Obviously, we will be needing each other very much, so you're perfectly right. Finance, I won't say much about it because I'm not a politician, but it's very obvious that this cannot come from the medical part of the government finance, because that's not a medical issue, that's a state resilience issue, that's a taxpayer issue as far as I'm concerned. The burden the industry has to take, that's to be discussed, but it's not from the medical budget. And your question about the minorities or endangered groups, elderly, that is a very difficult question, because the harder the, let's talk about war. If you're in war or you have an Article 5 situation where you have thousands of patients and millions of refugees coming in, you will shift your efforts. You must shift it. You must triage. And obviously, it's never okay to let go of someone, but you will have to focus. For us, that means we provide a lot of provisionary care, colonoscopies, breast cancer prevention, all these things that are very important in peace times, but we must think about what do we have to lay back and how do we focus. There will be no option as to do that. But it's an issue, and this needs to be addressed, and it will be addressed differently in the countries because that has to do with the society in the country. So I don't think this can be organized on an EU level. And last but not least, to the question from the BMA, education, that's an important thing. I think the association may want to say something, but with our military, we have established that the primary assumption of qualifying all physicians to do war surgery is more than ridiculous. That's not going to work. And that same thing, don't put the GPs in the hospitals and have them hold hooks, because that's also a waste of resources. I mean, you can train a monkey to hold a hook. Sorry, I'm not a surgeon, you can tell. You need surgeons, but hook holders you can train. You don't need other physicians to do stuff that they're way overqualified. So you need everyone in place, which does not mean that we need to train the population, everyone, first aid, and we need to train physicians and nurses and emergency PAs and all of these people more into the kind of wounds we're going to see. And by the way, infectious diseases, a big issue, especially the ones brought to us by by vicious force. Yes, there needs to be training. Training needs to be adapted, but the assumption that we all become war surgeons now in a second qualification, I think, is over the top and just not possible, but maybe close.
Thank you. Yeah, Dr. Helander.
Thank you. So first of all, think about the nurses. We have we talk a lot these issues when I was working in the Helsinki University Hospital, because it's not only that how the nurses are involved, but what about the families and who is taking care of the kids at that time when the nurses, because that is the background, that is the backbone that everything goes smoothly. So I think that it's in a way that we always talk about multidisciplinary teams, so that for example, in the hospitals, the nurses are part of it, so that the information is the key, that it's really circles around. So I think that maybe, well, let's say 10 years ago, the situation was different, but now I'm in a way positive in that sense, that that's a very important thing. And then if you think about the finance and the companies, we have been discussing a lot of this, and we, in a way, there is these questions about risk sharing, so that we, in a way, think that, of course, it's as much benefit for the companies as well that everything works. So I think the risk sharing is one of the options we have been discussing in the governmental level, and I think this is a part of the, as I was referring, the health sector growth strategy, because it's all the ministries, and there are a lot of companies as well discussing, and we have two big finances, Business Finland and the Academy of Finland, which has been in discussions as well. And then if you think about the UK and you said about the skills, so I think that they're a little bit different in Finland. We don't have military hospitals. We don't. The whole military capacity, or let's say the support, comes from the healthcare, from the counties for the hospitals, so that they are not particularly, let's say, educated to let's say in the military actions, so that I think that and as I said, that it's only by rehearsing. So that is true that there is still lacking the skills. And just to referring, we had the visit from Sweden, the Ministry of Health, who said that now you can come to our country because they have so many shots and you know, the assassins. So that it sounds horrible, but she said that it's so totally different situation nowadays, still in the very nearby countries. But that is true that I think that now we are in a way looking at it a little bit differently. But I think that is a different situation. And then if you think about the vulnerable people, that is, we notice that because we have that army, mandatory army, so that the military service, so that we can increase that up to the 900,000, and we notice that there are many people who are, in a way, in that capacity that they can't really serve in the field, but they want to participate. There are they can be involved in cybersecurity, and they want to be involved even though they don't have a, let's say, 100% capacity. And I think that is one thing, that they are really greatly committed. And then, of course, as said, the elderly people. I think that one of the things that we had, that winter war, and everybody was involved. I think we still have that history, that everybody is important. We need everyone. So I think that maybe that is the one thing. And as I said, there is a social and health together in our ministry, so that we can, in a way, support that. Thank you.
Thank you, Dr. Helander. Dr. Hagenmiller, final words from you, and then we'll wrap.
Yeah, maybe just to finance, there is one thing that we haven't discussed. It's just allocating dual-use capabilities in the healthcare to the matching it to the 1.5% from NATO. That's on work that's ongoing. There is a huge resistance, but there is that kind of idea. It will tap into a certain pocket amount. And then the other thing is just about workforce. There are also some ideas how to scale training. also online AI complemented in this and that, and also the topic of credentialing, so that you can empower someone who has, let's say, lower qualification to do something very specific for this area, but with the label you can do that. That's the legal stuff that is also applicable to other countries. And this again, this is EU stuff. We need to make it happen, but this is on our top priority list.
Great, thank you so much. So we are at time. Can I just have a big hand for our panelists? And thank you for your very good engagement this morning, the brilliant insights and questions, and for your rapt attention. It really is appreciated. A few little takeaways from what we heard. We heard that practice makes perfect. We don't need to dream up our strategies. We need to make them happen. We need to learn from action and learn from those scenarios. Trust is the foundation of everything. If we lose our public, we lose the war. And then resilience begins with us. And I think as we all think about going away for the summer and think about resetting, maybe we can also reset our personal plans for resilience so that we show up in this work having done our bit at home. And I want to thank our brilliant hosts, the GMA and the KBV, for putting on this event. And if we just give them a round of applause, please. Thank you all so much for your time this morning. It's been great. That's now a wrap. Thank you so much.
Thank you.
So?
Thank you.
Thank you, thank you, thank you.
Thank you.